The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome. Thank you for joining us for today's webinar, Cell-Based Therapies, organised by the ORS Basic Science Education Committee. My name is Martin Stoddart from the AO Research Institute in Davos, and I'm a member of the Basic Science Education Committee at the Orthopaedic Research Society, and I will be your moderator for today's webinar. Please be aware that this webinar is being recorded and it will be posted on the ORS website. You will be notified via email when it is ready for viewing. All webinar participants will be muted during the presentation. If you have any questions, please type them into the questions box in the menu located on the right-hand side of your screen. We will address as many questions at the end of the presentations as possible. I am very pleased to announce that today we have two very exciting speakers for you, Dr. Jason Dragoo and Dr. Robert Mauck. Our first speaker will be Dr. Jason Dragoo from Stanford University. Jason Dragoo is an Associate Professor of Orthopedic Surgery at Stanford University. He obtained his medical degree from the University of Arizona, and he now specializes in orthopedic surgery and sports medicine. He currently serves as team physician for numerous elite athletic associations, including the US Ski Team, the US Olympic Committee, and Stanford University Athletics. Even with this busy schedule, he still finds time to perform basic and clinical research, which has led to many advances in the use of biologics to augment tissue healing, including applications of platelet-rich plasma and autologous growth factors, cartilage regeneration using adult adipose-derived stem cells, and the development of second-generation methods and autologous products for tissue repair. He has published over 60 papers, 2 textbooks, as well as numerous book chapters. Thank you for joining us, Dr. Dragoo.
Well, thank you, Martin, and good afternoon or evening, everyone, and thank you for joining us today. As I was thumbing through my disclosures, I wanted to start by saying that creating a talk in cell-based therapy we quickly realized was a very broad topic, and so Rob and I compartmentalized it a little bit and decided to focus our talk on cartilage. However, some of the same points, mechanisms, and types of cell choices really could be applied to any type of tissue regeneration, including bone and muscle. But as for cartilage, just as the other tissues, there are 2 main types of tissues. First are the chondrocytes, or the more adult cells of cartilage, and the other are the progenitor cells. And we'll talk about use of both in regenerative medicine today. We'll start with chondrocytes first, and one of the first and oldest techniques using adult cells is autologous chondrocyte implantation. This is a procedure, as you can see from my cursor area, where first you identify a cartilage lesion within a patient, and then take a little cartilage biopsy on the margin of the articular surface, which we consider a less weight-bearing portion of the joint. Then this is just sent then to the laboratory for approximately 2 weeks, where it's then sent back to the surgeon in a vial. The cells are then harvested from the vial and injected after initially procuring a periosteal patch from the proximal tibia, which is then sewn on to the area, and the cells are injected beneath. This first generation ACI didn't work great because of problems with the periosteal flap. So therefore, the second generation was then used a collagen scaffold, which was synthetic, and most recent is the advent of MACI, or matrix-assisted collagen implantation. And this is where the technology currently resides. In the United States, there is 2 products that are going down the FDA pipeline. The first is NeoCart. You can see the picture on the upper right-hand portion, where the chondrocytes are then sent to the laboratory and seeded on this matrix, which then could be cut into custom shapes and implanted either arthroscopically or using an open technique. But as you see, the projection of the FDA clearance is not till 2017, so still second generations are used today in the United States. Another product closely related is NovoCart, here with a projected completion of the FDA process in 2021. But here, same, a thicker, different type of matrix, but still the same chondrocytes that are loaded onto it, and again, can be cut at the time of surgery. and implanted. The main problem with autologous chondrocyte implantation has been proving superiority compared to easier one surgical type of technique such as microfracture. And again, this involves 2 surgeries. It is much more costly, but the randomized control trials do show a little bit of improvement in comparison to microfracture, but as you see from the slide, not much. And that has always been the burden of proof for this particular technique. Here is a recent article just showing the phase 2 FDA results, and by looking at the graph on the right side, you can see the NeoCart in comparison to microfracture, that on key indices of performance, there's just not a whole lot of difference. A new player in the field is de novo, which is distinctly different than ACI in many ways. Number one, it uses allogenic cartilage, so a second surgery is not necessary. Second, it's juvenile chondrocytes, and this has been thoroughly explored, where the juvenile chondrocytes have much higher regenerative potential than adults. You can see the particles here then are secured in the patient using fibrin glue, and although this is a new technique with current level 4 evidence, it is still quite promising, and at least this is one surgical technique or surgery rather than 2. As far as the progenitor cells, there's 2 main types in modern-day medicine that are used clinically. One is the bone marrow-derived, otherwise known as mesenchymal stem cells, and the other is the adipose-derived stem cell. I think first, taking a step back and to discuss why stem cells may, why would that be plausible in the first place? Why do we need to worry about using these type of cells? And it goes back to the early 90s, a classic article here from the animal model. You see here an area of cartilage transplant that was taken by first creating a defect, and then on the back table the cartilage was minced and then replanted back into the same lesion. And 6 weeks later we saw an interesting phenomenon. First, you see the black arrows in the center are the cells that are forming the tide mark. Well, these cartilage cells were at the base of the cartilage as it anchors into bone, but were then mixed up in the back table and then ended up in the center of the cartilage regeneration. The important concept of this is that the adult cells have zonal memory, or they grow up to have one specific job within the cartilage and they don't forget it. This is different than the immature cells, where they don't know what they're supposed to do when they grow up, so they have a much easier time annealing to the surrounding cartilage. As you see here, the chondrocytes did not heal to the surrounding cartilage, and as well the underlying bone. So we get significant advantages by using more immature cells in the clinical state. One of the oldest stem cell techniques is microfracture, which is the most commonly performed cartilage regeneration technique in the world. This is picture number C, or letter C, here on the far right. That is the sharp microfracture awl, which is used to access the stem cells within the bone marrow. Drilling, which is also used throughout the world, is used as a standard drill bit to access the stem cells within the marrow. And the center picture is abrasion arthroplasty, which has largely been abandoned because the bleeding occurs because of removal of the subchondral bone. And it is recently recognized that this bone underneath the cartilage is of utmost importance for healthy cartilage to regenerate, so therefore is performed much less often. The microfracture technique is quite simple. It only requires one surgery, but the key caveats are these 4 parts to the technique. Number one, to remove the rest of the cartilage. So it is not possible to save cartilage at the base of a lesion, make the wall stable and vertical with healthy cartilage surrounding it, and perhaps most importantly is to remove the calcified cartilage layer of the cartilage by scraping with a curette, as in the regenerate cartilage will not stick to the underlying bone if the calcified cartilage layer is present. And finally, making the microfracture holes with the awl seen here in the lower picture. Well, microfracture is undergoing a renaissance here because we're learning a whole lot more about that technique and how we were really wrong previously when performing it. We used to think that it is good to punch as many holes as possible, such as the upper right picture, and we now know that that is not advantageous. because there needs to be good structural bone in between each of the microfracture punctures, and so therefore fewer holes may be more optimal. Second, we thought that if you see fat droplets, as you see by my cursor here in the top picture, or blood coming from the area of the microfracture puncture, indicates that we had far enough of a access into the bone marrow to access the stem cells. And we now have evidence to suggest that this isn't true. And a depth of around 6 millimeters is preferable and actually leads to, number one, a higher stem cell content to come into the regenerate area, and number two, a higher quality of cartilage regeneration. This has led to a renaissance of surgical instruments. The old instruments are to the right here. We see a short, squatty, fatter type of instruments that do not go far enough into the bone marrow, versus the new generation microfracture awls are much longer and more slender, and therefore could get deeper into the bone marrow. The tip configuration has also changed from a bullet type of design, and here at the bottom you see how it really compacts the surrounding bone together, versus the newer types of microfracture instruments do not produce any reaction of the surrounding bone. Also different is the access to the marrow cavity. Here we see the triangular lesion of the microfracture awl. You see that it cannot, by its very design, go very deep into the area where the stem cells reside. This is versus the two new types of microdrilling and nanofracture, which go much deeper into the bone marrow, therefore more easily access the stem cells in the perivascular space. Here are some CTs by Dr. Walsh here that show a couple of interesting phenomenon here about the different techniques of microfracture. Number one, the standard technique, we see compressed bone, thickened bone around the area of the microfracture, and collapse of the channels here by the hollow area, where you see this is the space where the stem cells come into the lesion to turn into the cartilage. This is versus the new type of techniques, which are much deeper, you see, into the marrow cavity. And then there is, if it's deeper, many more vascular channels then to allow the stem cells to migrate up into the area of the cartilage lesion. One of the new understandings over the past few years is that the health of the subchondral bone is of utmost importance. Therefore, when we see the MRIs, typically on T2 MRI images, we can see big regions of bone marrow edema, as well as cystic change below the cartilage surface. And we have increasing evidence to suggest that microfracture, or actually any other cartilage regeneration technique, doesn't work as well because of the altered bone below the area of the missing cartilage. It started back in 2007 when this clever study looked at contrast MRIs and showed that there was actually less perfusion in the area of the bone marrow edema. So therefore, less blood flow, there may be less progenitor cells available here. Another recent understanding is the whole hypertrophy of the subchondral bone. This subchondral hypertrophy is known to decrease results of the procedure and may be a simple example of Wolff's Law. For example, we're trying to get stem cells to come out of the bone marrow, and if the stresses around the cartilage lesion are too high, then the cells will have a choice in whether or not to turn into bone or cartilage. So therefore, excessive forces, they may turn into bone, therefore thickening the plate and thickening the area and growing bone into the cartilage lesion and decreasing the space for cartilage. Again, this has led to higher reoperation rates and decreased success of the procedures. And this phenomenon is now becoming more acknowledged, and this may alter the decisions on postoperative weight bearing or the use of modalities such as offloading bracing. Biocartilage is another product that has been used to augment the microfracture procedure. This has no cells within it, but it is devitalized and decellularized cartilage matrix. This is a toothpaste type of consistency, So the microfracture technique is then performed below the area of this, and then the toothpaste, so to speak, is then squirted on top to really gain a three-dimensional matrix for the microfracture regenerate. When this has been studied, this is not the exact system, but when three-dimensional scaffolds have been used in conjunction with microfracture, there has not been improvement in clinical results, however. So the jury is out of whether or not the addition of a matrix on top of the microfracture is clinically beneficial. What about stem cells? Well, the FDA in the United States has clearly weighed in on this of late 2012 and has clearly won the right to regulate what we do in the United States with the use of stem cells. They've clearly laid out their policy, which is on this slide, and as far as the stem cells are concerned, this will be the most important take-home slide that I'll be showing today. It really shows what we're allowed to do and what we're not allowed to do, as if we're going to use this in our clinic, we would want to stay out of trouble, of course, with the FDA and regulatory bodies. The good news is that we're allowed to use autologous stem cells in our office and operating room as of now. We can add autologous blood from that patient to the stem cells. We could even make PRP from it. We could produce fibrin glue from the plasma of that particular patient, and we can centrifuge the cells. But that's about all we can do besides implant them. The asterisks at the bottom are two special caveats that have been cleared by the FDA. Number one, the only allograft stem cells are allograft bone marrow stem cells contained within the bone marrow grafts, or therefore the FDA says you can use these as long as you use the graft that contains them. The other is the amniotic fluid and amniotic cells. This has been also cleared by the FDA, but it's interesting to read the literature, the safety data regarding these two classes of stem cells, and there really isn't a whole lot out there. So I would just use caution yet that this is very early for these two classes of stem cells without much evidence of safety or efficacy. So stay tuned on those, but be careful with their current use in clinical practice despite the FDA clearance. Now the list on the right is what's not allowed. You're not allowed to culture cells in any way, and if you do, then you must file for a medication type of clearance through the FDA. You are not allowed to take the cells out of the operating room or the clinic of which you've harvested the cells. You're not allowed to sort them, to purify any of the allograft cells within the bone marrow. You're not allowed to add any growth factors from other sources besides the human that the stem cells are harvested from. And you're not allowed to use any enzymes, any collagenase or anything else to aid in the harvest of these cells. Well, can you use this in the clinic today? Sure. But this is a cash-only proposition, and many clinics have really done well with this part of their clinical offerings, charging on an average of $4,000 to $8,000 per injection. And CPT codes, and I think this is more in the United States, there is no CPT codes for stem cell transplant of this type, and you can only bill for the ultrasound-guided injection. Well, here's the two types of stem cells. We'll go over them and their proof of clinical utility here. Bone marrow cells are harvested mostly from bone marrow of the iliac crest. This is done by a very simple procedure, and I'll run this video here to show you. They can be accessed through the posterior superior iliac spine or the anterior superior iliac spine. This can be done in the clinic, believe it or not. You can anesthetize the skin, subcutaneous tissue, and the periosteum above the bone. Then any sort of instrument, it doesn't have to be fancy, Jamshidi needle, etc., can be placed within the tables, making sure you're pointing away from the bowel contents, and then aspirating the bone marrow directly, a very easy procedure to perform. The research does show that you need to move the needle tip around if you're going to be aspirating a lot of the marrow to increase your stem cell yield. There is many manufacturers that offer commercial systems to help with this bone marrow harvest. The top three are highlighted in yellow only because they come with a centrifuge to help concentrate the bone marrow aspirate. Here's what one of these concentration systems looks like. But the bottom line is that the bone marrow cells are very few within all the other cells contained within the bone marrow, maybe something like 0.01%. So therefore, any type of augmenting and concentration of the stem cell population may be indicated. We are currently running studies to understand how these commercial systems work and if they do indeed concentrate the mesenchymal stem cells. Early results show that they actually do increase the amount of stem cells that are available, but they also do a fantastic job of increasing the amount of red blood cells and white blood cells within the aspirate as well. This may be okay, but certain applications such as injection in the joint for symptoms of osteoarthritis, injections of high amounts of red blood cells and white blood cells may not be indicated, may induce inflammation, and so therefore may not be a good choice as far as these bone marrow concentration systems are concerned. One of the things we've learned about stem cell medicine is if you are trying to regenerate a tissue of choice, try to harvest the stem cells within that compartment. Meaning if you're trying to make bone, go for bone marrow-derived stem cells. And they do a much better job of making bone. If you're trying to make fat, use the adipose-derived stem cells. The problem comes in with cartilage, where we can't really harvest enough of the cartilage-derived stem cells, so therefore we have to use one of the other two populations, and the jury is out as to which one of these is the best. There is certainly some evidence in the literature to suggest that the use of bone marrow cells certainly does improve the symptoms of arthritis or regeneration of tissues. There are many human clinical trials going on throughout the globe. These are highlighted in yellow. So if you wish to send your patient out of the clinic into another country, these are the places where the clinical trials are being performed. What about adipose-derived stem cells? A relatively newcomer as far as the stem cell field, but they have been widely adapted because of many reasons. Easy harvest, number one, but the biggest is a large cellular yield. This negate the need for culture expansion, and again, in the United States, when it's not really even allowed, it has been huge, and therefore is gaining wide acceptance and certainly being used much more often within the clinic. These can now be harvested arthroscopically through simple arthroscopy techniques, which makes it easier than for the orthopedic surgeon. Here on the left, we have the Aquavage fat system, FDA approved for collecting fat from liposuction or arthroscopy. And to the right, you see the standard arthroscopic setup here, where we have the standard shaver, and you see the arthroscopic images here of the condyle, where the shaver is held very close to the condyle to, again, not harvest much of the infrapatellar fat pad, but at the same time, the fat pad is then sucked into this Aquavage harvest system and then can be further processed. Here is the only FDA-approved device for concentrating adipose-derived stem cells. And this is another centrifuge device which is optimized for fat. And here you can see the different layers that you see in the tan cells here are the adipose-derived stem cell concentration. We did some work here to really understand how these systems work and if there really is a large amount of adipose-derived stem cells, and we see that there's actually two distinct populations of stem cells that are harvested. The upper arrow is the adipose-derived stem cells from the fat, and the lower arrow is stem cells from the synovium. And you can see by the percentage that the number of cells that can be used from these have high amounts of stem cell markers, so pretty intriguing cellular population. There is some studies in the literature to also show that the adipose-derived stem cells are clinically usable and do alter the course of disease and aid in the regeneration of tissues. However, the randomized controlled trial studies, the high-level evidence is clearly missing. We're starting trials at Stanford here to really put these cells to the test. This is a stem cell trial where the cells are arthroscopically harvested. There is no puncture into the underlying bone marrow, and these are placed on FDA-approved wound matrix within the joint and compared to microfracture in a randomized fashion. Here is randomized trials throughout the globe. And here you see this is a stem cell injection in Korea, where on the left side you see the grade 4 arthritis at arthroscopy, and 6 months later is the second look showing some substantial regeneration of cartilage. Again, I have not looked at this data, but this is published data by this company. However, this is not the only time I've seen really successful results like this. As far as the human clinical trials throughout the globe, United States will soon turn yellow, as well as the other countries in Asia and Europe. What about amniotic fluid and cells? I have tried to contact the companies as well as look on the databases for data, and there really is essentially no data to suggest two things. Number one, do these cells work as far as regenerative therapy? And number two, what is in amniotic fluid and how many cells come in the vial that you order from the company? And there is not really at least any understanding that I have seen from the companies themselves of how much cells are contained within these treatments and how many growth factors and what types of growth factors are present. So again, FDA approved by the, FDA approved, but stay tuned, be careful. There's not a whole lot of safety or other data available for this cell population. In summary, biologic and stem cell therapy is certainly here in the clinic today, and human clinical trials will pave the way for both reimbursement as well as ethical use of stem cells within medicine. In the United States, the FDA will continue to shape what we're allowed to do and what we're not allowed to do over the next 20 years, but it will certainly be changing here shortly. And there will be more widespread use of the stem cells within the clinic as the years go by. So thank you very much, and looking forward to answering a few questions after Rob's talk.
Thank you, Dr. Dragoo, for sharing your insight and expertise with us today. Again, for everybody listening to this webinar, please remember, if you have any questions, click on the questions box in the menu on the right-hand side of your screen, and we will take them all at the end of the session. Our second speaker today is Dr. Robert Mauck. Dr. Mauck obtained his undergraduate degrees in biochemistry and biomedical engineering at Columbia University in 1998 and completed his PhD at Columbia in the Cellular Engineering and Musculoskeletal Biomechanics Laboratories in 2003. Between 2003 and 2005, he was a postdoc at the National Institutes of Health with Dr. Rocky Twan, after which he moved to the University of Pennsylvania, where he has since developed a new research program in the McKay Orthopedic Research Laboratory. He is currently an associate professor of orthopedic surgery and bioengineering. The Mauck lab develops novel tissue engineering and regenerative medicine approaches for the restoration of the musculoskeletal soft tissues, with a particular interest in articular cartilage, the knee meniscus, and the intervertebral disc. He has published over 100 papers and is active in numerous societies, including the ORS. Thank you for joining us, Dr. Mauck.
Thank you, Martin, for that great introduction. It's really a pleasure to be talking to everyone today, and it's fantastic to follow up Dr. Dragoo's excellent presentation on some of the clinical aspects of cell-based therapeutics for cartilage repair. So what I thought I would do today is sort of riff on that and maybe give a perspective of a scientist and engineer and talk about things that we're doing in the lab or thinking about on the single cell level, at the in vitro level, and in the use of in vivo models towards the translation of some of these newer therapeutics. So I need not give any introduction to articular cartilage injuries. It was so well presented before. I'll just simply say that focal cartilage defects have a limited healing potential, and of course the incidence of osteoarthritis in the U.S. and worldwide is significant and rising as the population ages. And really my perspective on this is that if we are to engineer functional replacements, it's imperative that they either have at the time of implantation or have the capacity to achieve near-native mechanical properties, as well as the ability to integrate with the remaining native tissue. And the general framework that I think most of us in the field of cartilage regenerative medicine or tissue engineering use is this sort of concept of going from injury through repair to regeneration and eventually functional restoration of the native tissue. And when we think about that, we think about cell biology and stem cell biology, so ideas of identifying autologous cell sources, which was discussed in detail, methods for potentially their expansion and isolation, and then ways that we can enhance the phenotypic specification that we so desire, so either inducing that capacity or maintaining the stability of these selected stem cell sources. Now, on the other hand, when I put my engineer hat on, I think about tissue engineering methods as well, and I think about ways to grow and evaluate tissue in the lab, and this includes bioreactors, biomaterials, and media formulations, and then further ways to assemble and test these engineered tissues in complex anatomic structures. And of course, for me, the ultimate sort of resolution of this aspiration is to push these into preclinical models where we can get a true test of efficacy. And so today I'm going to give you a couple of snippets of ideas, and really it's all predicated on information presented on this slide. So this is just sort of the distillate, in my opinion, of the formation of engineered cartilage, and that is we start with some cell source, be it chondrocytes or a conjugate progenitor cell. Typically we'll combine it with a biomaterial. In this case I'll talk a lot about hydrogels. And then we provide nutrients and differentiation cues, and most importantly time, such as to grow a functional tissue replacement. And really what we're talking about here is we're talking about establishing and maintaining a positive growth trajectory for that engineered material or that engineered construct, both in vitro and once we place it in vitro. And so today I thought I'd show some vignettes on 3 different topics. First, talking about trajectories in engineered cartilage at the single cell level. Then moving on and talking about trajectories in engineered tissue at the in vitro level, the construct level. And closing out with some newer thoughts that we've been confronted with regarding the context of a trajectory in vivo cartilage repair and what we do know and don't know on that topic. So to begin, at the single cell level, one of the principal questions that many of us ask ourselves is, when MSCs differentiate, do they do so at the same rate and to the same extent? And the quick and easy answer to that can be found in this histological section. So this is just a hydrogel we use in the lab seeded with bone marrow-derived mesenchymal stem cells, and it's an early time point. And what you're seeing here is the proteoglycan deposition about the cells at this early time point. And you can see we have some high performers and we have some low performers already in this what is a heterogeneous population of mesenchymal stem cells. And of course, heterogeneity exists at many levels. Each donor has a different array of stem cells within the bone marrow, for example. The stem cell niche, as Dr. Dragoo mentioned, from which the cells come can define to some extent their potentiality. Furthermore, even within a specific niche, say bone marrow, you'll see subpopulations of cells, some with good properties, some with not so good properties. And then even at the single cell level, so if you start with a clonal population of cells, we see heterogeneity, and I'll show you some examples of that. So why is this all important? It's important because when we take measures of a stem cell populations, the ensemble or average measurement is pretty coarse, and it can in fact mask subpopulations that could either be very good at cartilage repair or could compromise the ongoing cartilage repair that's being mediated by the main stem cell cohort. So one of the things that we've been thinking about a lot lately is, can we develop and use single-cell analysis tools to select progenitor cell populations whose trajectories are more suited for cartilage tissue engineering. Now, the way we went about doing this is we took a typical bone marrow mesenchymal stem cell isolation, and we cultured it on a plate for 10 days. And after that time period, what you see are individual colonies that all started from a single cell source. So having identified those colonies, you can circumscribe them, and you can selectively trypsinize an individual colony, so a starting population of cells that should be relatively homogeneous, and you can passage them distinct from one another. Now, the first thing you see after a passage or two is that within a single donor, so each box here represents a single clone, for example, the stem cells within that clone are distinct from one another. Moreover, if you compare left to right boxes, you see that between two clones, the clones are morphologically distinct from one another. So the question then is, do they have different differentiation trajectories? So in order to answer such questions, you need to develop single-cell quantitative analysis tools. And so working with a collaborator here at Penn, Arjun Raj, we've been using a quantitative fluorescent in situ hybridization method. And essentially what this involves is creating small RNA-fish probes that can be annealed to the mRNA of a gene of interest. And we develop a series of chondrogenic probe sets for aggregate, COMP, or cartilage oligomeric matrix protein, and GAPDH. Now, using such probes, you can identify single mRNA species in individual cells. So these are just mesenchymal stem cells in monolayer culture, and what you're seeing, these little white dots, are individual signals of mRNA, single mRNAs within these cells. And so what this method allows us to do is quantify, to say specifically in a specific cell, how many copies of aggregate mRNA are being produced at any one time. Now, we can do this both for mixed populations of stem cells as well as these clonal populations that we have derived. So this is just showing 6 different clonal populations. And the data I'm presenting to you now is aggregate copy number, and this is what's called a Violin Plot, so it's the distribution and range of aggregate mRNA in this undifferentiated condition. So what you can see is there's a baseline heterogeneity amongst the clones. What's more interesting is that when we induce chondrogenesis by adding TGF-beta, we see very different responses amongst the clones. So some come on quite strongly, some not so strongly. And when we look at additional markers like COMP, you can see the same kind of heterogeneity amongst clones. So we can take away from studies like this the idea that not every clone responds the same. So some can be quite robust in, say, 2 chondrogenic markers, but still show a very heterogeneous response, whereas other clones might be strong, say, in aggregate, but not so good at producing COMP. And so the conclusion from studies like this are that clonal populations of stem cells are inherently different from one another. Indeed, they have different chondrogenic trajectories. What's more, when we induce chondrogenesis of these stem cell populations, we see an emergent heterogeneity. The cells become even more different between one another and between different clones. And so this really tells us in a translational sense that we should be thinking about selectable markers that allow us to sort stable MSC populations with improved functional matrix production capacity for use in some of our tissue engineering efforts. Okay, so that was a story about trajectories at the single cell level. Let's talk about trajectories at the tissue level, and specifically let's try to answer questions about what is the growth trajectory of an engineered construct, and what are the factors that change that growth trajectory, and further, can we manipulate this growth trajectory to improve functional outcomes? And finally, we can ask questions about how a construct is maturing and what that might mean with respect to how it interacts with adjacent structures. And I'll take you through this step by step. So when we talk about optimization of culture parameters in tissue engineering, really what we're talking about is modification of the trajectory. So for 20 years, we've been combining cells with various biomaterials. We've been altering the cell type and density within those materials. We've been adding various chemical factors and mechanical factors to try to coax these cells to produce the most robust tissue possible, in this case, engineered articular cartilage. And I'm going to give the ending to the story first and tell you that this 20-year effort has led to many, many successes by multiple labs really across the country and across the world. And indeed, today we can make engineered constructs that have properties that are in the range of native tissue in terms of their biomechanical and biochemical properties. But really the question is, how do we influence the rate at which this tissue forms, and how do we modify these trajectories? So in my lab, we work with a number of different hydrogels, but one of the most common ones is hyaluronic acid. This is, of course, a component of the normal extracellular matrix of cartilage. And working with a colleague of ours here at Penn, Jason Dragoo, we've been working with modified versions of HA that have been methacrylated. And what this does is it allows us to assemble these long chains of polysaccharides into a covalently cross-linked network. And indeed, we can do this both in vitro to make constructs to study, as well as in situ within a defect in the cartilage. So using this material, we've been manipulating the trajectory of engineered constructs over the last really decade. One of the simplest things you can do with respect to changing the material is simply change the density of the material that you're surrounding the cells with. And so in this study, we changed the density of our HA hydrogel from 1% to 2% to 5%. And in doing so, we were able to influence the growth characteristics of the engineered constructs. So what you can see from this data at the bottom, the histology, is that when the macromer density, the density of the encapsulating hydrogel, is too high, the cells produce matrix, but it's sequestered just around those cells. Whereas when you're using a softer material with less polymer density, the cells can produce matrix and distribute it more readily throughout the extracellular space. And this influences the growth characteristics, where at high densities, the cells and constructs do mature, of course. However, they do so to a much greater extent in these lower densities. So the materials can change the trajectory. Another simple thing you can do to change the growth trajectory is by changing the seeding density. So in the case of a low seeding density, the cells make matrix, but it takes quite some time for that matrix to interact with different sources of that material. Compare that to the case in a high cell density, where the cells are closer to one another, and so the matrix that they form can interact more readily and more quickly. And indeed, if you look at data here, you can see that changing the seeding density just by a factor of 3 in the context of a permissive hydrogel that allows the matrix to expand and interact with other sources of extracellular matrix leads to about a 3-fold increase in the overall mechanical properties of the construct. We can also alter the trajectory of growth with ligand presentation. So up till now, I've just been talking about a bare backbone of the hydrogel being hyaluronic acid, which of course does have some biologic inputs to cell behaviors, but we can add additional functionalities onto these backbones. In a recent study, we were considering how cartilage develops, and we thought about N-cadherin. This is a molecule that mediates sort of self-self or cell-to-cell adhesion in the developing limb bud, and it's important for chondrogenesis. So we modified our hyaluronic acid system and appended N-cadherin moieties into the forming gel such that cells could make connections with that. And results from this study showed that this biologic presentation of a ligand could influence the amount of matrix that was formed as well as the rate at which the matrix was formed, and so we could alter the trajectory. The final point that I'll make about changing trajectories in vitro is the point of dynamic loading. So in the field of tissue engineering, of course, for many years, folks have been making bioreactors, these mechanical devices. A simple one is shown here on the left, that can interface with the tissue engineered construct. By applying loading at different times and to different magnitudes, one can influence the rate and the extent to which engineered cartilage constructs mature. So what we've seen so far is that a variety of systems exist that are successful in perturbing cartilage growth to optimize the formed tissue to make it more functional. And indeed, some of these approach normal cartilage levels of biomechanics and biochemical properties. But the remaining question we have to ask ourselves is there a theoretical framework through which one can monitor and predict the growth trajectory? And really specifically, how soon do you know that a perturbation is a good one that might positively influence the outcome that you're looking for? And then to extend that a bit further, the question is, can we apply such considerations to a clinically relevant situation? And in our case, we were quite interested recently in how constructs integrate with native tissue. So the reason we were interested in how constructs integrate with native tissue was brought up by the last speaker when he was mentioning how native tissue really has a poor time integrating with itself. Whereas the ideal that we would have is that we would mature an implant to the maximum level, at the same time optimizing its ability to interface with the surrounding tissue. However, the general consensus in the field is that as constructs mature, they probably have less and less integration potential. Now, the truth of the matter is that if you look at all the studies out there in the literature, it's sort of a hodgepodge where sometimes it's an improving correlation and sometimes it's a decreasing correlation, and sometimes there seems to be no correlation between integration and maturation at time of implantation. So we wanted to ask ourselves, how do we appropriately select this engineered construct for in vivo implantation, and is there a way that we can maximize its maturation as well as its ability to integrate? So I had a very talented postdoc, Matt Fisher, who's now faculty at NC State, and what Matt was realizing was that you can look at the data, the growth of the modulus of this engineered tissue over time, and you can fit a function to this nonlinear increase in mechanics. And once you have a continuous function, you can, of course, take the first derivative of it, and so you can separate then the maturation state, so how stiff it is, from the maturation rate, and that is how stiff is it, or how quickly is it becoming stiff at any one point. A simple illustration of this is the example I gave you previously of low seating density versus high seating density. So you can see the trajectory of the low seating density, the trajectory of the high seating density, and our model now fit to this improved properties over time. And then, of course, it's quite simple from that to calculate the maturation rate of each of these conditions. And you can get interesting things from such analyses. So you can find, for example, that early on, these two different formulations have pretty similar states, but they have quite different rates of maturation at this 5-week time point. If we wait to longer periods in the culture, we see that the rates of maturation have essentially gone to zero. However, the time history of their different rates accumulated such that there's a different state at this late time point. Matt then went on to investigate how this rate versus state phenomenon influenced integration, and for this he used a cartilage defect model. So what he did is he grew these engineered constructs over a 17-week period, and then at select time points that encapsulated this dynamic change in state and rate, he took those engineered constructs and then implanted them into an artificial defect in vitro. He then cultured for 3 or 6 weeks, and he measured how well did the tissue mechanically integrate with the surrounding native tissue. And what he found from this was quite interesting. So when he tried to correlate the integration strength to the modulus at the time of implantation, he found a very weak correlation. However, when he correlated the same thing, integration strength, to the rate of growth at the time of implantation, he found a very strong correlation to this integration capacity. And so we think that this sort of approach, this idea of mapping the trajectory, allows us to separate the rate from the state, and it might be important in terms of our selecting the most appropriate time for implantation of engineered constructs in an in vivo setting. And furthermore, it can be generalized such that we can use it to explore variations in biomaterial, soluble factor, and mechanical stimulations to maximize this rate prior to translation. Now, the final point I wanted to talk about today just briefly is the final translation of an engineered construct to the in vivo space. And really we want to understand, does a tissue integrate during this active growth state in vivo as well, and does the repair environment itself present its own trajectory? So over the last 3 or 4 years, we've been developing an animal model of a chondral defect. There are a variety of these out there, and I would encourage you to read this literature widely. We chose a skeletally immature Yucatan mini pig because the cartilage was thick enough for us to work with. We could induce stable implantation. It has some endogenous healing capacity, and we were able to make multiple defects within this space. In a recent study, we used this Yucatan mini pig model in a trochlear group defect, and we examined 5 different groups. And these were pretty simple groups. We were just trying to lay the groundwork for our study. So we had a partial thickness defect that we left untreated. We had a full thickness defect that we left untreated. We had a full thickness defect that we treated with microfracture. And we had a full thickness defect that we treated with autologous cartilage transplantation, or ACT. So we moved a piece of cartilage from one zone to another zone. At 6 weeks after the procedure, we did histological scoring using the ICRS-2 as well as micro-CT to look at both the cartilage and the bone morphology. So this is what the tissue looks like with saffron and no fast green staining. You can see differences amongst them, and scoring them using the ICER-S2 gives us a general sense of their overall healing capacity. So we see interesting things. So the partial thickness untreated defect has a pretty good overall assessment, as does this articular cartilage transfer that we did to repair a full thickness defect. Our poorest performing groups were our untreated defects and those that were treated with microfracture, and really the same sort of observations were made for matrix staining. The interesting thing that we saw, however, was that despite the fact that the ACT was good overall, we did see this very significant clefts at the boundaries of this implant. So we had the lowest values for integration in this group. And so this model, in our hands at least, is representing quite a lot of data in the literature. And some of our findings are somewhat consistent with our in vitro trajectory-based tissue engineering findings, in that the most mature construct, the articular cartilage itself, integrated the poorest. But we did see a trajectory that we weren't looking for in carrying out this study, and that is when we looked at the subchondral bone in these animals, we found rampant remodeling of the subchondral bone beneath the defect site. We could break this down and look at the different classes of defects we'd created, and we see very little remodeling in our partial thickness defects, but quite extensive remodeling in the region under the defect in all of our full thickness defects. If you went far enough away from the original subchondral plate, this resolved back to native tissue levels. So this severity of focal chondral defects seemed to be dictating in this model system the amount of bony remodeling that was going on. And it only occurred with our full thickness defects and was independent of how we treated them. And this, when we look back to the literature, had been observed in previous studies. However, it hadn't been truly rigorously investigated. We did one further step, and we wondered if it was a function of age, so we looked at adult mini pigs. So these are about 18 months old at the time of surgery, and we see that this subchondral remodeling is largely gone in these older pigs. However, the repair capacity in these older pigs is much reduced as well. So I'll just conclude with a couple of closing statements. I think it's important in the field of cell-based repair to consider the different trajectories that exist at multiple length scales, from the single cell level to the tissue engineered construct level to the in vivo environment. And each of these can impact the success of an engineered construct. I think that applying an engineering perspective to this to derive quantitative understanding of these growth trajectories might be useful for judging novel technologies and for optimizing growth in vitro prior to in vivo implantation. It might also give us a sense of what the best time to implant a construct is. And finally, it's important to recognize in all of these studies that the in vivo environment presents its own trajectory. And it's not just soluble features of that in vivo microenvironment, but also is the dynamic mechanical environment of the subchondral bone to which, and other adjacent structures to which this cartilage is healing. So with that, I'd just like to acknowledge my collaborators in lab, especially the folks who did most of the work I presented to you today, our funding sources, and thank you for your attention, and both Jason and I would be happy to take any and all of your questions.
Thank you, Dr. Mauck, for sharing your insight and expertise with us today. Again, I invite listeners to add your questions and place them in the questions box in the menu on the right-hand side of your screen. So, some of the questions we've been having from the audience so far. We'll start off with one for Dr. Dragoo. One question has come in as, how are the cells for AC and MACI characterized before their return to the clinic?
They're essentially just growing in on adherent cell culture as you would in a standard lab, otherwise not characterized. There's some additional types of studies that do characterize the cells a little different. Those are, there's a company that is out of Europe which does do a little bit further diagnostics of the cells to really attempt to provide a more guided cell population. However, the cartilage cells that basically survive on a petri dish are representative of the cells that go back into the vial with essentially, besides the screening for infection, etc., are the ones that you get back without further testing.
Thank you very much. And on a very similar related topic, are there synovial MSC markers which are selective compared to, say, for example, adipose selective MSC markers, or are they just general markers for stem cells?
Well, what a great question. And at least as far as I understand, there is no markers that are unique to the synovial cells. They stain for a higher degree of CD44. But other than that, there isn't a great way to determine the cells of synovial origin compared to the cells from the fat origin, let's just say. So a better understanding or a better overall agreement on progenitor type of markers, less of an agreement on which markers are more unique or proving adipose derivation versus synovial derivation. And for our purposes in the clinic, we could see that there was actually two different qualities of tissue. So they, one floated and was surrounded by the fat, and the other didn't in saline. So we understood that it was in different origins, likely, and otherwise those cells did stain for higher amounts of CD44, again, not proving all the way that those cells are from synovial origin, but we did do histology, and it did look like it was synovial tissue that was morselized on that lower area. So again, not a whole lot of pure evidence of the difference in the cells, but all the cells tend to have a different milieu of markers, and that's the reason for, in the literature, maybe the confusion or the arguments of which markers are most specific or are most beneficial to prove you have stem cells. The overall thought is the more markers you have, the better off you can prove that your cells are going to have progenitor-like qualities.
And Martin, if I could add to that,
sure.
One of my favorite papers on this topic was by a person. The first author's last name was Moretti, and I think it was in Tissue Engineering, maybe 5 or 6 or 7 years ago now. And they were using, I believe, just bone marrow-derived stem cells at that time, and they were looking at surface marker expression. And then they were going downstream and looking at functional outcomes based on surface marker expression. They even went so far as to separate them into different clones, so starting from a single cell population. And what they found essentially was that the surface markers were not predictive of the functional capacity of the stem cell population itself. And so I think what the markers are useful for right now is telling you that you have a stem cell, but they're not specifically geared towards telling you whether it's a good stem cell or not.
Thank you very much. And then a question for Dr. Mauck. Have you managed to do the fish analysis in 3D culture systems such as aggregate or pellet culture?
So we have not yet done it in pellet culture or aggregate culture, but we have been making engineered microtissues. So these are small, tiny hydrogels into which the mesenchymal stem cells are seeded. And this allows us to do the fish in a three-dimensional environment and to apply some of those perturbations in trajectory that I was discussing.
And a follow-on question for Dr. Mauck. When you were looking at your clonal populations with the varying trajectories, do you have any idea of what kind of influence crosstalk would have? Because you have clonal populations which then do not talk to each other, whereas if you have mixed population, there is paracrine signaling between the different cell types.
Yeah, this is an absolutely wonderful question, and I guess I don't know the absolute answer to it. When I was talking about the differences in measurements and subpopulations, I was saying that some subpopulations might be quite good at cartilage formation, and other subpopulations might not be good. And in some cases, those subpopulations, the minor fractions, say, may be antithetical to cartilage formation, but in other cases it might be absolutely essential for the health and vitality of the entire cohort of cells. And I think this is some some critical basic science that we need to do and understand so as to be able to optimize the cell populations for implantation.
Thank you. And the question for Dr. Dragoo, you mentioned there was the combined microfracture and bioscaffold had little effect on the cartilage repair. Do you have any suggestions as to why that would be the case and what ideal scaffold might be required?
Well, one of the things that I think has been difficult is the migration of the cells to be uniformly distributed within that three-dimensional matrix, because the cells are coming out, of course, with the blood from the marrow, and it clots rather quickly. Even at arthroscopy, if you turn off the fluid for, let's just say, 5 minutes and go back in, that area of the cartilage defect is completely clotted over. So when you look at the histology of some of the three-dimensional matrix, it is not uniform seeding, and I think that is one of the reasons why these matrix have struggled, because the superficial layers of the matrix have not been populated as much as the deeper layers. And so maybe this would be a reason to have a more porous type of three-dimensional matrix, because maybe Rob could comment on this as well from a tissue engineering perspective. Really establishing a three-dimensional matrix for cartilage growth is certainly something that improves the quality of the tissue. So for it really not to in microfracture is interesting. But really, again, we're talking more of a fibro-cartilage type of construct where there is a lot of collagen and early clotting, which, again, I think non-uniform distribution of the cells is one of the biggest reasons.
And Dr. Mauck, would you like to add?
Sure, certainly. So we've just recently finished a series of studies in our pig model using a variety of different acellular biomaterials to influence repair. And I think Dr. Dragoo is absolutely correct that the material itself, choosing the material is really critically important. So in this recent study, we were looking at a synthetic nanofibrous network and a biologic nanofibrous network that could be degraded by endogenous enzymes. And it was quite interesting to see the residence time of these two different materials within the cartilage defect. And it did seem like the materials that were resident longer, while maybe initially promising, were not tailored appropriately to degrade as the tissue was trying to form. And so the material itself might actually get in the way of or impede the resolution of the defect. So this is an absolutely critical concept that we need to gather more data on.
Thank you. And when considering the source of cells, it was shown in the Saras study that MACI and microfracture essentially had very little in the way of difference in efficacy, and yet one is a differentiated cell and one is a mesenchymal stromal cell. Would you have any thoughts on why that might be the case?
I think that the summary is the clinical outcomes. So where the ACI and the more adult chondrocyte type of techniques do show improvements in histology or histologic improvements, it looks more like cartilage, less intermixing of the collagen stranding, therefore indicating at least a component of fibrohyaline or fibrocartilage. But when you look at the results, and I think that's what the take-home message is for patients, for surgeons, is that there's very little difference in overall outcome. Now, the key thing I think to consider is long-term results, because these studies are all very good studies, but they're all shorter-term studies just due to the expense of running research like this. However, if you were to look at those same patients in 20 years, there may be a substantial difference. I'm just guessing, but quite possibly a substantial difference where the ACI would be performing better or the chondrocytes performing better because, again, they started with better histology scores. It just hasn't been borne out very well, and I think it has been borne out that there is plenty of problems with microfracture, so therefore we need to change the technique, we need to improve upon it, And so there's plenty of room for improvement in both techniques. So I think from the chondrocyte, using juvenile cells with much higher regenerative capacity is one step for them, and of course all the reasons why microfracture itself is being better understood, and we can hopefully improve those results as well.
And a follow-on question there for Dr. Mauck. How do you think the animal model would affect the kind of long-term results you would see? Is there anything we could use which is predictive from the animal model to try to work out what we would see in a patient in 20 years' time?
No, this is an interesting question as well. Animal models are, I think, complicated and maybe beset by the same issues that we have with clinical studies, and that is they cost quite a lot to do, and so it's difficult to look at very, very long-term outcomes. I think the thing with an animal model that is perhaps of great utility is that you can do terminal assays where you can address other features of the tissue that has formed that's simply impossible to do in a clinical scenario. And so it's not even that favorable anymore to do biopsies, for example, in people. Very few people will sign up for that. So we're left with instruments for measuring pain and activity by self-reporting and by questionnaire, and MRI, so non-invasive things. So in an animal system, you can go back in and you can take the tissue back out and you can ask very difficult questions of it. In the study I was mentioning, our most recent long-term study at 12 weeks, we used the same sort of outcomes that we had used previously. So we used ICRS2 grading, and we could find significant differences between groups that looked quite promising. We also added another outcome parameter, or outcome measure, and that was the mechanical testing. And there we were sad to find that despite the fact that some of the cartilage looked quite good, the mechanical functionality of that cartilage was not good. And so I think this is what you can maybe see and understand in an animal study that's simply not possible in the clinics at present with current technology.
And a question for Dr. Dragoo. Just out of interest, one of the questions has come in, when you have progressive inflammation and degradation within the joint, how well does that, or how does that affect the cell survival and functionality?
Well, what an outstanding question. And we are, from the clinical side, becoming more and more, we have more and more of the understanding of the climate of inflammation and how deleterious that could be for cartilage regeneration, and including further degradation of osteoarthritis in general, of a disease that was, when we went to medical school, that was thought to be a non-inflammatory disease, and it is now understood that at least a big segment of folks with cartilage defects and osteoarthritis do have an inflammatory component. And if you look at those components, whether it be MMPs, such as MMP1 and interstitial collagenase, these are enzymatic insults to the area of cartilage regeneration. So although it hasn't been proven as well, because the science has kind of lagged in that's the next step of the research that hasn't really been performed a lot yet. But the clinical understanding of that is definitely there, and therefore combating, all methods of combating post-operative inflammation is really ideal to improving the result. And again, it's more anecdotal than proven by research, but I honestly feel, and just from just the clinical research on the side, is going to be more and more of an understanding as time goes by how important it is to ward away and to treat the inflammation when we're treating cartilage lesions.
Thank you. And now we're coming close to the end of our allotted time, and I've just got one more question which I would open to both of you to try to maybe give people an idea of what kind of things they should be looking for in the future. What do you think is the greatest barrier for current cell therapies? Is it the science, the cost, the insurance policies, the patient? Maybe to Dragoo first.
Oh, well, yeah, another fantastic question. And And I think there's lots of barriers, and I'll just briefly list them. Number one is reimbursement, and that is something where physicians want to offer this, but of course the insurance says, well, it's experimental, I'm not going to pay you for that. So at least in the United States it's become a problem. Second of all, one of the best questions I've heard is, is stem cell therapy and this regenerative therapy even ethical to give to our patients, because we just don't have high-level research to suggest that it works. And what a great question, and I would say yes, as long as we're disclosing that we really don't know the end of the end answer of this, and we're working towards that if that's disclosed. But even just having the evidence there is a clinical barrier. And of course, one of the biggest things is working within the parameters of the FDA. And it sounds like small things, such as, well, you're not allowed to use collagenase to work to help release the stem cells before you implant them. Well, the truth is, in tissue engineering and in animal studies, we essentially always use that. Mm-hmm. And that releases the cells within the matrix. So we have all these beautiful histology and beautiful animal studies, and they seem to reliably work. But when we get into the clinics, where we can't use those critical steps that we've used for years and years in all of our other models, it really is a significant barrier. So methods to overcome those shortcomings of preparing the cells to allow them to do work is certainly a barrier which I hope we can overcome in the next 10 years.
Thank you. And Dr. Mauck?
So I guess my perspective as a basic scientist, the first barrier that always comes to mind is funding. It's difficult, I think, to, we would love to carry out long-term large animal studies, but it's very difficult to raise sufficient funding for that. So I think a focus by the NIH and maybe the FDA in collaboration on building systems to enable that would be good. Dr. Dragoo was mentioning sort of studies of efficacy and the issue of reimbursement. And the same thing, I think, translates down to the sort of basic science level, where if you have a good idea, it's sometimes difficult to demonstrate sufficient efficacy so as to make it financially significant to a company to invest in that technology as well. So I think showing efficacy and showing it for a long period of time is a difficult undertaking.
So thank you both for some very valuable advice. And that we're getting to the end now. So as a reminder, this webinar will be uploaded onto the ORS website within the coming week. You'll be notified via email when you can get access to the recording. And lastly, upon exiting the webinar, you'll be asked to complete a short evaluation. Please complete the evaluation and make any suggestions you can on how we can improve for moving forward. We'd really appreciate any suggestions. So thank you everyone again in advance for completing the survey and joining us today, and thank you again to both speakers. This concludes the webinar Cell-Based Therapies.